Hey everybody, hope you guys are doing good today. So we're going to go ahead and get started with our very first board review session to kick off the series for this block. And so we're going to cover a bunch of different topics today. And this is meant to be kind of a general pediatrics board review, but we're going to cover things like ear, nose, and throat, some allergy immunology stuff, some dermatology stuff. Really, there are probably about 5 different topics that we will cover, and it's not meant to be all-inclusive, and I just want to remind you guys of that. So this is really just meant to be a start to everything and give you guys some high-yield topics that hopefully you can then take and start to look more into as you prepare for your boards. Hopefully, it'll also allow you to recognize those areas that you might be stronger in, the areas you might be weaker in, and it's really going to be based on the content specifications. So I hate that a lot of this is going to be just kind of lecture, kind of factoids thrown at you, but hopefully we'll be able to cover a lot of ground in a short amount of time. Again, this will remain available for you guys even after you guys leave here, so you can always log back into the YouTube channel to be able to check it out. So without further ado, we will go ahead and get started here. So again, we're just going to cover a bunch of different topical areas or broad overviews, and the ones we're going to be covering are ENT, allergy, immunology, very, very briefly, dermatology, some well child and preventative care, and then some adolescent medicine. There will also be an email sent out to everyone that will include some other PowerPoints for review, things like Dr. Norton's clinical dermatology lecture that he did for you guys earlier in the year that really helps to classify some things when it comes to derm stuff. So to start with, we're going to jump into ear, nose, and throat stuff. And just so you guys know, we'll kind of create an outline for how much of the entire test it accounts for, and then what the main components of the topical area are. So eye, ears, nose, and throat accounts for about 4% of the entire content of the test. And that's what the majority of the small content areas will account for, is about 4%. It's broken into 2 different components: clinical presentations, so what the disease would look like as they're showing up, so the diagnostic part of things, and then further subdividing those things into diseases, disorders, and conditions in terms of if it's inflammatory or infectious, if it's a structural or anatomic problem, and then if it's related to trauma or injury. So we'll start with the eye. The clinical presentations that you guys are really going to want to focus on from a broad category standpoint are the things of redness, things that cause redness to the eye, things that cause tearing to the eye, things that cause discharge to the eye, and things that can cause painful disorders of the eye. So the first question, obviously, you want to ask yourself, and a lot of this is just the questions you would ask if a patient showed up. So what is it, unilateral or bilateral? What are some of the potential differential diagnoses for a red eye? Is it something that could play into one of those other presentations of things like trauma, like Stevens-Johnson's? Are there other concomitant problems that could cause redness? Same thing for tearing. Thinking about it's an anatomical reason for it, something like nasal lacrimal duct stenosis, congenital glaucoma, or is it more of a acquired condition, corneal abrasions, viral diseases, those sort of things. Discharge, the branch points that you'll think about are, is it purulent, which tends to be more likely to be bacterial, versus mucopurulent or mucoid, which tends to be more associated with nasal lacrimal duct stenosis and dacrocystitis. Watery eyes, you think more of irritants, including viral diseases, but iritis and obstruction can cause more watery discharges, and also thinking about things like allergic disease causing more watery discharge. And then painful eye conditions include things like foreign bodies and corneal abrasions. Obviously, trauma will cause that, but it's more of a, is this a deep pain type of thing, which might represent some closed angle glaucoma, or does this seem to be more of an irritation type of thing? And always thinking about photophobia as a reason for it, or things like contact lens usage and more systemic diseases. So speaking of photophobia, the causes of it include corneal abrasions like contact use or systemic diseases in foreign bodies. It can happen with glaucoma and albinism in infants. So aniridia is sometimes the tip off for that. If it's a single eye with use of bright light, you do want to think about intermittent exotropia. And then there are the non-ocular systemic diseases that can cause photophobia that you want to keep in mind as well. Leukorrhea, I think, is something that we all know about and something that hopefully will jump right to your mind in terms of retinoblastoma. But don't forget that can also occur in other disease processes like retinopathy of prematurity, congenital cataracts, retinal detachment, and then infections like Toxocara can cause leukorrhea. Refractive errors, just remember when it comes to the treatment of refractive errors in kids, if you ever see somebody that are mentioning laser correction or LASIK therapy, that is not recommended in children. The jury is still out in adolescents, but usually you're not going to be asked about that. But in children, refractive errors are not treated with laser correction. And there are things that predispose people to risk factors of refractive errors, including being premature, having a parental history, and then there are certain syndromic diseases which will lead you to having more high likelihood of refractive errors, things like Down syndrome, Stickler syndrome, Marfan syndrome with a lens detachment, and Ehlers-Danlos. So think about the connective tissue disorders when you think about people with refractive errors. Some of the conditions that can happen with inflammatory and infectious diseases that you might want to read more about are ophthalmia neonatorum, which is in that list of diagnosis of gonorrheal and chlamydial diseases, the bacterial conjunctivitis, viral conjunctivitis, and we'll touch on all these things here in just a second. So when it comes to ophthalmia neonatorium, what you'll see is the redness and swelling and discharge within the first month of life. It can also be caused by some of the things that we do to people, babies when they're born. If somebody uses a silver nitrate solution as opposed to the erythromycin style solution for the eye treatment directly at birth, that can cause this ophthalmia neonatorum. Gonorrhea and chlamydia obviously are the big offenders, but don't forget about Staph aureus as a reason. And then when it comes to time course, gonorrhea is the earlier one, usually within the first few days, and chlamydia occurring weeks later. Bacterial conjunctivitis can be a whole list of different things, but the main culprits are Staph aureus and group A strep, and then also the ear, nose, and throat bugs that you typically will see, things like strep pneumo and MCAT. Bartonella Hensley can cause a bacterial conjunctivitis if you see anything related to a macular star in the stem of a question. That really should tip you off to a Bartonella Hensley or cat scratch disease. And usually the eye disease of Bartonella Hensley lacks the preauricular adenopathy that is a regular kind of thing that you'll see with some of the other Bartonella Hensley infections. In terms of viral conjunctivitis, adenovirus is by far and away the most common, and you will have some significant preauricular adenopathy along with that, and systemic symptoms. Obviously, there are a bunch of other viruses that can cause it, but adeno is by far and away the most common. Allergic conjunctivitis, there should be something else to tell you that allergy is going on, whether those are some of the allergic stigmata, some itching that goes along with the eye disease, some mucoid discharge. Topical and systemic treatment is really going to be the key for the allergic conjunctivitis, and the use of steroids is not recommended for allergic conjunctivitis alone. We don't want to put steroids in the eyes if we can avoid it most of the time. And then obviously avoiding whatever the root cause is. Some of the buzzwords that you'll hear for glaucoma in terms of the symptomatology that you'll see include first year swelling of the globe within the first year of life with excessive tearing. Anytime there's a baby with photophobia, glaucoma should jump to the forefront of your mind. The words of corneal clouding is something else that you'll see, and also something that you'll see in some of the syndromes that are related to glaucoma, things like some of the mucopolysaccharidoses. It's usually not a red inflamed eye in children like what we see in adults. That usually is something that happens much later on. Some of the systemic diseases associated with glaucoma include Sturge-Weber and oculocerebral renal syndrome, otherwise known as Lowe's syndrome, and there is a higher incidence of people with Pierre-Robin sequence. Uveitis is one of those conditions, inflammatory conditions that's associated typically with systemic inflammatory diseases, and they're broken up into two categories: anterior versus posterior. So anterior uveitis is usually pauciarticular, JIA, things like Crohn's disease, and then more kind of systemic diseases that can be acquired, things like syphilis, tuberculosis, sarcoid, and Lyme disease. Some of the HLA-B27 diseases, things like ankylosing spondylitis, and Reiter syndrome, and psoriasis are associated more likely with the anterior uveitis. Versus posterior uveitis, usually you're going to be considering that with infectious etiologies, and most commonly thinking through things that are congenital infections. So things like toxoplasmosis, syphilis, rubella, the torch infections, ocular candidiasis, HIV, CMV, toxocara, and toxocani are the ones that are associated most commonly with posterior uveitis. So again, anterior uveitis is typically a systemic disease, as well as some acquired conditions. Versus posterior uveitis, usually we want to think about more of our infections that are more congenital in nature. I'm not going to spend a ton of time talking about preorbital and orbital cellulitis. Hopefully you guys have had enough exposure to know what bugs you need to be thinking about with those things, but also realize that most commonly it's going to be extension from sinus disease, and we'll talk more about that here in a little bit. Structural or anatomical abnormalities. So these are things that are highly tested upon, but rarely seen. So you'll want to go back and review some of this stuff, especially some of the disorders of the cornea, the retina, and the lens, which will be the kind of the next section of this. So when it comes to the eyelid, the blepharitis is most commonly due to Staph aureus. The treatment is topical erythromycin. Hordeolums and chalazions are obstructions of different portions of the eyelid itself. Warm compresses are typically the mainstay of treatment, but not hot compresses. And then when you have somebody who has ptosis, especially if it's unilateral, you're going to want to think about something like a third nerve palsy or Horner syndrome, making sure you evaluate the iris as well. And then for bilateral ptosis, myasthenia gravis should be the thing that comes directly to your mind. Nasolacrimal duct obstruction is one of the more common things that you'll see, especially in infants with eye disorders. And what they really want you to know is it one or both lids, and thinking through, okay, can you do gentle massage versus do you need to do surgical treatment and probing for recurrent diseases. A dacrocystocele is an obstruction that leads to a significant amount of swelling. There's a bluish discoloration at the inferior aspect of the eye itself, and most often it gets confused for a hemangioma. It does require some probing and can lead to dacrocystitis and sepsis, so it can result in some significant disease processes, and the most common bugs that will cause it are Staph aureus and strep pneumo. So not only does it usually require probing to open the area up, but it can also become infected. And those usually require either IV or oral antibiotics, depending on how sick the child is. And then iris disorders, a lot of times these are associated with syndromes. I'm thinking about the colobomas and the charge syndromes and things like that with the keyhole appearances. Aniridia is the complete absence of the iris. It's an autosomal dominant inheritance pattern, and it is associated with Wilms tumor. You will want to know that association. And then oculocutaneous albinism, again, is due to a tyranase deficiency. Oftentimes it will present with photophobia in kids. This is a more systemic disease process, but does lead to some visual dysfunction. And then don't forget about leash nodules with neurofibromatosis. Corneal diseases include things like corneal clouding. We had talked about mucopolysaccharidosis. Glaucoma is a cause for that. Certainly systemic infections can cause it. Tumors can cause corneal clouding. But don't forget about cystinosis as one of those things, especially in a light-skinned, light-haired, blue-eyed child. Cystinosis should really come to your mind as something that can cause corneal clouding. Keratitis usually, again, is due to either infections with things like adenovirus or herpes, or persistent contact lens usage without cleaning and taking them out. The bacterium of choice there is acanthus amoebas, excuse me. And the treatment is typically with topical antivirals and steroids, depending on what the cause is of the keratitis. Disorders of the retina include retinopathy of prematurity. You are going to want to review the different zones and classifications of ROP. They will be asking you about that. And remembering that those at lower zones and higher stages are at more risk of progression of disease and is more severe disease. Retinal hemorrhages usually will resolve within the first month of life if they are associated with birth trauma, but obviously if it's after that, you want to think about non-accidental trauma. Most of the time you're going to have other injuries associated with a non-accidental trauma and not just retinal hemorrhages. Remember that shearing force that causes the retinal hemorrhages is a fairly significant force. Retinoblastoma obviously is the most common ocular malignancy. It's autosomal dominant inheritance and always requires enucleation of the affected eye. And retinal detachment is a fairly uncommon thing, can be associated with floaters in kids, seen in some of the connective tissue disorders, and treatment is typically surgery. Lens disorders include things like cataracts, and dislocation. You can see some of the causes there, especially infectious causes, but also don't forget about galactosemia as a cause of congenital cataracts. And then we talked about some of the lens dislocation things with some of the connective tissue disorders, but also homocystinuria and syphilis. Disorders of the optic nerve will result in visual field cuts, as well as problems with color and pupillary response deficits with central vision loss. Hypoplasia of the optic nerve is associated with an absent septum pellucidum, typically seen on MRI or ultrasound. Anybody with absent septum pellucidum, by definition, has panhypopituitarism and septo-optic dysplasia. Those children also should undergo workup for other abnormalities associated with panhypopit, including growth hormones, looking for DI, and other disorders. And then finally, papilledema, when it comes to disorders that are structural or anatomic in nature, is typically a bilateral disease. It's very rarely a unilateral disease. Don't forget about vitamin A excess and tetracycline usage as causes of papilledema and pseudotumor or idiopathic intracranial hypertension. Infections can cause it, tumors can cause it, and then clotting disorders also will cause papilledema. So just think through kind of what could cause some increased pressure around that optic nerve. So just a couple words about trauma and injury. So fluorescein is really the thing you're going to want to use to evaluate for a foreign body. Irrigation with saline is another important aspect of that, also using antibiotic ointment. Ecchymoses around the eye certainly can represent a orbital or soft tissue trauma. If there's pain with the eye movement, you do have to worry about a orbital floor fracture. And if there are raccoon eyes, so bilateral ecchymoses around the eye, do think about a basilar skull fracture and the other problems that can occur with that. A hyphema is something that is a very high risk of bleeding into the anterior chamber. Those patients that are at high risk include patients with sickle cell disease, and the reason that they're at high risk for clot and other bleeding disorders is because of the intraocular pressure that can lead to vision loss. So those kids are treated very, very aggressively with lots of different topical antibiotics, bed rest with elevation of the head of the bed. Moving on to disorders of the ear. So you'll want to know about hearing loss and the 4 different types of hearing loss, and think through kind of what the differential for those are, including, is it conductive hearing loss? Is it sensorineuronal? Is it congenital, or is it acquired? The most common reason for hearing loss is going to be conductive hearing loss, usually due to a dysfunction of the tympanic membrane or middle ear, and effusions can cause it. Sensorineuronal hearing loss is usually a cranial nerve 7 problem. You can see the incidence listed there, and is typically picked up in the newborn nursery screening. Congenital hearing loss, about 50% is non-genetic, and about 70% of the genetic hearing loss is non-syndromic. But if it is syndromic, it's likely due to a connexin 26 deficiency. And then acquired hearing loss may be genetic, but delayed in onset. So things like Alport syndrome can have it. So just because somebody is older when they present with hearing loss does not mean it is not a congenital issue, but may have just been predisposed to have some degree of hearing that then worsened. Other causes of acquired hearing loss outside of just trauma, barotrauma, include noise, obviously, meningitis, and certain medications. So when we talk about the different diseases and conditions of the ear, inflammatory and infectious diseases, you all know about otitis media. Hopefully you've taken some time to review about it. You really want to review tympanograms. They're not just going to ask you if a child has otitis media. They are going to give you a tympanogram and want you to look at that. And so please make sure you take some time to review the different tympanograms and what they mean in terms of acute infectious disease, effusions, hearing loss, and that sort of thing. Otitis externa, similarly, hopefully you guys remember enough about that we're not going to spend a lot of time. Mastoiditis is a complication of acute otitis media. Most of them occur in kids less than 2 years of age. It can result in meningitis and brain abscesses, so we want to make sure we're using IV antibiotics and surgery to treat those kids aggressively. And then the two pictures that you guys see here are sclerosis versus cholesteatomas. So the yellow discoloration is a cholesteatoma. It is a result of a recurrent disease. And the white is the sclerosis that occurs with recurrent infections. So just make sure that you differentiate between the two of them because they can look very, very similar on some of the pictures that they will show you. Some of the congenital structural anatomic abnormalities that you'll see include tags, pits, and cysts. The thing you want to remember about that is that it is associated with renal disease and that a diagnostic workup typically should be underdone for that. Bilateral disease increases the incidence of renal disease versus unilateral disease, and tags are less likely to cause problems than pits than cysts. And then trauma, obviously foreign body is an emergency if it's due to a button battery, and that is across the board for anything. Anytime you hear button battery, you need to get it out. The longer that it sits in there, the more likely it can cause a burn injury. Hematomas of the ear or the tympanic membrane are a purple discoloration that may lead to some necrosis. Excuse me. The hematomas of the pinna are things that can lead to necrosis because there's a lot of pressure that can be created there. A hematoma behind the TM is something that should be evaluated because that may represent a skull fracture. And so make sure anytime you see blood, which is purple behind the tympanic membrane, that it gets evaluated. When it comes to diseases of the nose, rhinosinusitis is something that you will see from time to time, obviously. Viral disease is the most common, and usually at age 5, kids have between 6 and 12 colds per year. Just remember that is a common disease process. And the complication that we worry about is obviously sinusitis and abscess formation. The incidence of sinusitis or abscess formation is higher after 10 days, higher with increased fever, higher in older children, and the complications of rhinosinusitis is abscess formation, whether that's preseptal or orbital cellulitis, Pott's puffy tumor, so a frontal sinusitis that develops into an area of swelling in the frontal sinus, and CT is a diagnostic area there. It can lead to sinus venous thrombosis and cavernous venous thrombosis and periosteal abscess formation. CT is the way you're going to diagnose that, and typically amoxicillin clavulanic acid is going to be your treatment of choice. Structural or anatomic areas to think about with regards to the nose include choanal atresia, which is typically a unilateral disease. It is the classic can't pass the catheter in the newborn period. Diagnostic test of choice is CAT scanning, and it is part of CHARGE syndrome. Bilateral choanal atresia does require an emergent oral airway, so don't anchor and think that it is only always going to be unilateral. It can be bilateral, and in that situation requires an oral airway. When it comes to trauma and injury of the nose, epistaxis by far and away is the most common thing we'll see, usually due to minor trauma and nose picking, but also because of inappropriate medication usage. And what I mean by that is either inappropriate technique or prolonged usage of medications. Less than 5% are bleeding disorders, with von Willebrand being the most common, presenting with nose bleeding. The times that it should be worked up, if there are a family history of bleeding disorders, if there are bleedings with minor procedures, spontaneous bleeding, if it happens before the age of 2, because most 2-year-olds don't pick their nose, bleeding that lasts longer than 30 minutes. And really the way we should be treating nosebleeds is by pinching the soft tissue for 5 continuous minutes. And afterwards, really telling them to prevent blowing their nose, to to make sure they're not dislodging the clot that happens. And that's probably the most common thing that happens, is that the clot formation that develops is dislodged by manipulation, which then leads to more bleeding. And so then people freak out. If somebody needs the use of Afrin or Surgicel to stop the bleeding, that at that point in time, an ENT should be evaluating to make sure that there aren't any vascular reasons for them to have bleeding. And again, foreign body. Within the nose, the most common presentation is going to be halitosis or bad breath. And again, button batteries are problems in kids. Disease of the throat, so stomatitis is something you guys want to think about, and really classifying it as aphthous stomatitis versus gingivostomatitis. Aphthous stomatitis are typically in the more anterior portions, small ulcers, and very painful. They last for 1 to 2 weeks and can be very recurrent. There are systemic diseases like Behçet's, Mediterranean fever diseases, and PFAPA associated with aphthous ulcers. Medications also can cause that, versus gingivostomatitis is usually due to HSV2, usually in those less than 3 years of age, can last 7 to 10 days. And if it is early on, you can treat them with systemic improvement with acyclovir. Tonsillitis, thinking more in the kind of posterior oral pharynx, is really associated with mono and cervical adenitis. Don't forget that in patients younger than 5, you may have a false negative monospot, and that greater than 10% variant lymphs is diagnostic for mono. Herpes angina and hand, foot, mouth usually is, again, more posterior in nature, related to Coxsackie virus and enteroviral infections. And then pharyngeoconjunctival fever most likely is associated with adenovirus, and you can see the other causes of things. Make sure you review pharyngitis, group A strep in particular, and the complications of it. Understand that gonorrhea and chlamydia can present with pharyngitis in the adolescent patient. And the school-age patient, if with a negative strep test, mycoplasma is at high likelihood in that patient. The only reason that we want to eliminate the carrier state for patients with recurrent pharyngitis is to eliminate the possibility of rheumatic fever and acute glomerulonephritis in those with recurrent infections or a family history of rheumatic fever or acute glomerulonephritis associated with group A strep. Review retropharyngeal abscesses versus peritonsillar abscesses, and you'll also want to look into the causes of parotitis and how that is going to present from time to time. The structural and anatomic diseases of the throat that you'll want to review include obstructive sleep apnea, and then disorders of the tongue. Geographic tongue are the areas that are devoid of papillae, versus a fissured tongue, which is very heavily associated with Down syndrome. A furry tongue is a tongue that's coated with what looks like fur, is associated usually with mouth breathing and drying of the tongue. And then the disorders that are associated with macroglossia, including Beckwith-Wiedemann syndrome, lymphangioma, Down syndrome, mucopolysaccharidosis. Those are all syndromes associated with macroglossia. Ankyloglossia or tongue tie is very, very common, and most require no treatment. The only time that it should require treatment is in a patient that is having difficulty feeding, leading to weight loss, and those that can't pass the gum line. So that it's a problem of extension of the tongue, but also elevation of the tongue. Typically, clipping of the tongue is the test of choice or the treatment of choice. Can be done in the office at the bedside by a practitioner or by an ENT, but most commonly they require no treatment. A tip-off to submucosal clefts include a bifid uvula, and those with submucosal clefts will have very hypernasal speech, even more so than what I have right now. 40% of them will go on to develop recurrent otitis media with effusion. So anybody with recurrent otitis media with effusion should undergo evaluation for a submucosal cleft. And then Pierre-Robin sequence is the sequence associated with micrognathia, cleft palate, glossoptosis, and an emergency of difficulty with ventilation. Those patients should be placed in the prone position because it brings their jaw forward and opens up their airway. All right. So that's it for ear, nose, and throat. Good half an hour's worth of talk. We'll move on to allergy and immunology next. And just know that this accounts for about 4% of the entire content of the test, and 2 sections, allergy and immunology, and there are 5 components of each. We'll touch base on some of the things in allergy, but not everything, and give you some broad kind of overview of some disorders of immune function with the 5 parts of disorders of immune function. So within allergy, urticaria and angioedema are areas that you want to think about. Urticaria is definitely inflammation and allergic response in the superficial dermis. Usually these lesions or wheals are up to 7 centimeters in diameter. They can coalesce, they can evolve over hours typically, and are self-resolving. They're much, much more common than true angioedema, and acute urticaria lasts less than 6 weeks. Chronic urticaria lasts greater than 6 weeks, and their treatment strategies are somewhat different. Most oftentimes for urticaria, what you're going to want to do is avoid them, use antihistamines. For more chronic urticaria, you're going to involve your allergist, immunologist, and potentially use corticosteroids. Angioedema is much more significant. It's much more systemic. It's much deeper. It's into the dermis and subcutaneous areas. It lasts up to 72 hours. It's non-pitting. It's typically asymmetrical. Remember that urticaria and angioedema can occur together, and about a quarter of the time that they do. Most of the time, both of them are IgE mediated with mast cell involvement, and some of the time it can be idiopathic in nature. Testing should be exposure specific, so the history is really going to guide you with what kind of testing should be done related to urticaria and angioedema. Infections can cause it. Medications are the other likely culprit when it comes to urticaria and angioedema. A quick review of anaphylaxis. Remember, it is a rapid onset after exposure of pruritus, anxiety, urticaria, angioedema, dyspnea, hypoventilation, and circulatory collapse. The reason that it happens so fast is because it is IgA mediated and because it occurs after exposure. The treatment obviously is avoidance, and then ABCs. So as soon as somebody shows up, breathing and circulation are of the utmost importance when it comes to anaphylaxis and how we take care of them. The medications are obviously IM epinephrine without delay and repeat every 15 to 20 minutes until resolution of the symptoms. Involvement of emergency medicine personnel should occur immediately after the use of IM epinephrine. The use of things like antihistamines, fluids, beta agonists are really reserved for when there is significant respiratory distress involved. Steroids are only meant to prevent the biphasic anaphylaxis that can happen and are typically not indicated. So for the purposes of the board exam, you're really not going to want to use steroids in patients with acute anaphylaxis. So to go back just for a second, we're not going to talk about allergic rhinitis, hypersensitivity reactions, or food allergy and oral allergies because we just have to limit this a little bit, but please make sure you go back and look at that stuff during your self-review. So when it comes to immunology, there are really 5 different types, and this chart should help you to remember, if you have no saintly clue of what kind of immunodeficiency somebody might have, what to guess. And so about 50% of all immunodeficiencies are going to be related to B-cell mediated or antibody mediated immunodeficiencies. About a quarter of them are going to be combined type. About 20% of them are going to be phagocytic. About 7% are going to be T-cell mediated, and only 2% are going to be complement-mediated immunodeficiency. So really, for those ones at the smaller ends of the spectrum, they should be giving you some fairly key clues to let you know it's a T-cell mediated or a complement-mediated immunodeficiency, and we'll go through some of that stuff here. So when it comes to B-cell mediated immunodeficiencies, remember they typically occur after 6 months of age or later. One caveat to that is premature babies. So babies born at prematurity may have an earlier onset of B-cell deficiency, or those with overwhelming infections, which deplete maternal stores of antibodies, certainly can be at increased risk. Presentation is usually recurrent sinopulmonary infections with typical respiratory pathogens. So the bugs that cause acute otitis media are the bugs you're going to see happening over and over and over again in patients with B-cell deficiencies. They sometimes just can't clear them despite appropriate antibiotics. The way you make the diagnosis for B-cell deficiencies is usually by antibody titers and immunoglobulin levels. Pre and post-vaccination titers are ways that you can do that, but dedicated immunoglobulin levels is the other way you would do that. The examples that you'll see of B cell deficiencies include IgA deficiency, which is by far and away the most common immunodeficiency, X-linked or Bruton's A globulinemia. There is an autosomal recessive form, which you will more than likely not be tested on, but do know that just because somebody is male or female does not mean they cannot have Bruton's A globulinemia. Common variable immunodeficiency, like the name says, is one of the most common diseases. It is a diagnosis of exclusion with less than expected antibody titers that you would see. And then transient hypogammaglobulinemia of infancy is the corollary in kids that are less than 2 years of age with common variable immunodeficiency. So it can't be distinguished between the two unless those less than 2 years of age. But if somebody has resolution of their hypogammaglobulinemia in infancy, they just had transient hypogammaglob. But if it does not resolve, it transitions to common variable immunodeficiency. T cell and combined type immunodeficiency usually have an earlier onset of disease process, usually at about a month of age. What you'll see here are atypical or recurrent pneumonias, recurrent thrush, failure to thrive and poor weight gain, recurrent secretory diarrhea, and the bugs that cause it are going to be the things that cause your B cell infections, along with fungal and viral infections, as well as some of the strange infections, the opportunistic infections. So basically what I would tell you to think about is think about somebody with advanced stage HIV disease and how they typically present, what kind of bugs they typically run into. Those are the same kind of presentations kids with T cell and combined type immunodeficiencies will have. The examples that you'll see include DiGeorge, which is a T cell aplasia because of thymic aplasia, severe combined immunodeficiency, which is a combined, obviously, immunodeficiency, hyper IgM syndrome, which is a combined type immunodeficiency, which results in an inability to class switch on the T cell, either due to CD40 or CD40 ligand, ataxia telangiectasia, and Wiskott-Aldrich syndrome. So those are all syndromes you're going to want to review in terms of what their presentation might come like. Things that show up with them, like the platelet disorders associated with Wiskott-Aldrich syndrome, the ataxia due to the Purkinje cell degeneration with ataxia telangiectasia, and some of the other things that go with catch-22 along with DiGeorge syndrome. Phagocytic immunodeficiencies can happen at any age, but usually during early infancy. Anytime you see somebody with recurrent skin or solid organ abscesses, they really should undergo a workup for phagocytic immunodeficiency, a pneumonia with atypical organisms, or recurrent dental infections. The organisms that cause problems in phagocytic immunodeficiencies are your catalase positive organisms, things like staph, serratia, your gram-negative organisms, E. coli, Klebsiella, Proteus, and some of your fungal things like Aspergillus. You're not going to see a lot of strep infections in patients with phagocytic immunodeficiency other than those with hyper IgE syndrome. And so leukocyte adhesion deficiency, the one that causes problems with delayed separation of the umbilical cord, is by far and away the most common phagocytic immunodeficiency, but things like Shirayama-Kagashi syndrome, chronic granulomatous disease, and hyper IgE syndrome, otherwise known as Job syndrome, which happens with a very pruritic dermatitis and recurrent boils and skin abscesses, are the different phagocytic immunodeficiencies you'll really want to know when it comes to the board examination. And then finally, complement-mediated immunodeficiency. So these can happen at any age, but usually in early infancy or adolescence are the two time periods where it will show up. The presentation are usually associated with autoimmune syndromes. So you'll usually have somebody who shows up with lupus, with JIA, with dermatomyositis, something like that, which might tip you off to a concatenate immunodeficiency. They are pyogenic infections, so staph and strep are very, very high on the list of causes, and there's a high incidence of glomerulonephritis associated with complement-mediated immunodeficiency, usually due to AGN, but so you want to think about group A strep associated disease. They're the B cell organisms, and anytime you see somebody with Neisseria meningitis, particularly without an exposure risk, you do want to think about a complement-mediated immunodeficiency. So the two major groups are the groups of early components versus those with terminal components. So the early components, there are really two main ones, C2 deficiency, which is by far and away the most common, and C3 deficiency. So C3 deficiency is associated with pneumonia, meningitis, and peritonitis, post-strep GN. C4 deficiency is is associated with things like lupus and other autoimmune diseases. So again, that hopefully will help you to classify if it's an early component disease, which one of the components you would be most worried about. And then the terminal components are usually the ones that involve the membrane attack complex, the problems with encapsulated organisms, as well as Neisseria species. And so recurrent meningococcal disease or gonococcal disease, despite adequate treatment, should prompt a workup for terminal component disease C5 through C9. All right. We're not going to spend a ton of time talking about dermatology. Like I said, we're going to provide you guys with Dr. Norton's kind of basics of dermatology, but we'll go through some of the things that you'll want to think a little bit about, particularly associated with some of the neurocutaneous syndromes. And so it counts for 4% of the test. It's broken into 4 subcategories. So clinical presentations of diseases is by far and away the most common thing you will see with the dermatology presentation. And then the 4 disorders and conditions you'll want to think about are the congenital and neonatal infection versus non-infection presentations, the acquired disease processes, so infection, inflammatory, immune mediated trauma disorders, things like burn injuries, pigmentary disorders, papules and nodules, vesicular lesions, and then please review acne and its treatment as well. Vascular lesions like hemangiomas are another big portion of the disease process and something you'll want to review in your skin and dermatology review. So when it comes to the neurocutaneous syndromes, just remember that it's derived from ectoderm embryologically. So all are at increased risk of CNS diseases, whether that's seizure disorders, developmental delay, stroke, you name it. Because it's derived from the same embryologic tissue, you do want to think about that in anybody presented with neurocutaneous syndromes. And so some examples that you guys can go back and review during your own time include Sturge-Weber, which is really a vascular proliferation. We think about the port wine stains, but don't think about deeper hemangiomas as well, and AVMs, which can occur. And usually seizures happen very early on. Incogniti pigmenti, which is one of Dr. Stallworth's obviously favorite disease processes, is one of the X-linked dominant diseases. Really it kind of is a progression of disease, starting in a blistery type formation in the neonatal period, usually in a linear distribution in the limbs and trunk, which then becomes kind of a warty type appearance. It does follow the lines of Blaschko, and anytime you see the whorls and swirls pattern or marble cake appearance, really think about incogniti pigmenti. Hypomelanosis of Ito has a stereotypical streak pattern of a whorled and mottled area of hypopigmentation, more than the hyperpigmentation of incogniti pigmenti that happens usually in infancy. And then don't forget about McCune-Albright, which is an irregular hyperpigmentation which does not cross the midline. It is usually associated with the lines of Blaschko and also associated with other endocrinopathies, things like hyperthyroidism, precocious puberty, hyperparathyroidism, Cushing's hypoprolactinemia. You can see the other things. Tuberous sclerosis is definitely an area that I think you guys need to review. Remember that is autosomal dominant in inheritance patterns. The fibrous angiomas that can kind of look like waxy appearance, sometimes confused with acne, is a very common way that is presented on the boards. Usually the nasolabial folds and cheeks are the predominant areas that those happen in, usually during adolescence. So obviously, again, confused with acne. There are the other different types of skin lesions that can happen with TS as well. And then there are the more neurologic problems with angiomas and gliomas, the intellectual disability, the renal angiomyolipomas. So don't forget, it's a tumor suppression problem with tuberous sclerosis, and that's the problem that can occur. It is that you can have increased risk of cancer as well. And then neurofibromatosis type 1 is autosomal dominant as well. Defect on chromosome 17. Don't forget there are 17 letters. And then it results in the different proliferation of McCaffrey spots, your neurofibromas, your gliomas, your hamartomas, all those kind of things. And then the associations of neurofibromatosis, which are problems with the kidneys, problems with the eyes, pulmonic stenosis, and all that kind of stuff. All right, moving on to preventative and well child care. So again, we're not going to cover everything here, but to give you guys an idea of some of the things that we wanted you guys to make sure to review, we're going to be providing you guys with all of the well child talks that the attendings do in CHALK in the pre-conference areas. So you'll get that as well as in the email. So this counts for the largest portion of the test when it comes to the different categories. So it counts for 8% of the entire content. So please don't avoid reviewing preventative and well child care because it does consist of the largest content area. And the 5 different domains of preventative and well child care include normal growth and development. So a lot of that will be gone over when the developmentalists go through their portion of the board review. Nutrition, which is a big portion of the test. Immunizations, so current recommendations and special circumstances. You don't need to necessarily memorize the entire schedule, but do know the special circumstances of immunizations. Screening and disease prevention, and then anticipatory guidance are the big ones. So when it comes to normal growth and development, please make sure to review growth curves, typical growth patterns in terms of when to expect the doubling of the weight, the tripling of the weight, attainment of height areas, the definition of failure to thrive, including the Z-scores that define mild, moderate, and severe failure to thrive or protein calorie malnutrition, and the definition of pediatric overweight versus obesity. So when it comes to nutrition, the things you'll want to take some time to review include the daily caloric, protein, and fat requirements based on age and prematurity. So remember that based on your age, you have a certain number of kcals per kg per day that you'll really want to have for adequate weight gain, and that's something you'll want to review. The particular nutritional deficiencies to review include calcium, phosphorus, and magnesium deficiencies. There will be multiple test questions on vitamin D deficiency, on calcium deficiency, on phosphorus deficiency, on magnesium deficiency. So those are things you'll want to review. I know everybody hates that little chart that Dr. Stallworth has, but please, please, please take the time to review that. Remember to look at the disorders associated with zinc deficiency, with copper deficiency, things like Menkes kinky hair disease, fluoride deficiency and its treatment is another big one that is often asked about how do you treat fluoride deficiency and iodine deficiency. Deficiencies of fat-soluble vitamins, A, D, E, and K, obviously associated with things like cystic fibrosis and malabsorptive disorders. But what do their deficiencies lead to, as well as what do the excess of those things lead to? In particular, vitamin A excess, which is a common test question. Not so much D, E, and K. Breastfeeding is something else that is commonly asked about nutritional areas for well child care. So the AAP, remember, recommends exclusive breastfeeding for the first 6 months of life when possible. And for those under 1,500 grams, so those born prematurely, if someone is going to breastfeed, you should be fortifying them until they get over that mark. And so make sure that you review that. There are contraindications to breastfeeding. Active tuberculosis is one of them. Galactosemia diagnosis in the baby is another one. If there's active varicella infections, and then certain medications may predispose infants from breastfeeding, including a amount of methadone per day. So if a mother is ongoing treatment for opioid addiction disorder, if they're receiving more than 40 milligrams of methadone per day, they really should be not breastfeeding that child. That they should be supplementing until they're able to get down to a lower amount of opioids that they're taking or methadone that they're taking. The indications for formula feeding include transient lactose intolerance for 2 to 4 weeks. So after somebody has had a acute infectious diarrhea and they have a lactase deficiency, a relative lactase deficiency, and a loss of their villi, that may be an indication for the use of soy for transient lactose intolerance. Galactosemia is obviously an indication for soy formula, but remember it does have some IgA cross-reactivity to cow's milk formula. So if you have somebody who has a cow's milk intolerance, not necessarily allergy, but intolerance, soy formula may be indicated. It may be contraindicated depending on what happens. And so just remember that when it comes to the use of soy. And then elemental formulas really are most helpful in malabsorptive disorders, special circumstances, failure to thrive being the big one. Not necessarily reflux. That is not the first line of treatment for gastroesophageal reflux, even though clinically it sometimes is. From the standpoint of the board test, that's not something that you're going to be doing. So everybody loves this chart, and hopefully you guys have spent enough time looking through it in chalk to feel semi-comfortable in doing it. But just remember that this is one of the key areas that you're going to want to review in terms of when the vaccination schedule is for children and adolescents. Some of the special circumstances associated with immunizations that you'll want to review are that it's not necessary to restart the series just because of an extended time period between dosing or because of missed doses. The big thing is don't give them early. There are minimum intervals you'll want to review about how long between vaccinations people should be having. There are vaccine adverse reactions, and there are three big categories: local, systemic, and allergic. Local is just pain and swelling. Usually seen with DTaP. Systemic is very common: fever, malaise, headaches, myalgias, just not feeling well. I mean, that's a systemic reaction and not an allergy. But allergy is true anaphylaxis, IgE-mediated hives, swelling, difficulty breathing, hypotension, shock, the things we mentioned earlier. So the two true contraindications to immunizations include severe anaphylaxis, allergy to a vaccine component, or following a prior dose, or if you have somebody who has encephalopathy not due to another cause within 7 days of the vaccination. So anybody with encephalopathy or severe anaphylactic reaction to a vaccine component or with a prior dose should not be getting them. Non-contraindications include minor illnesses, if somebody is on antibiotics, if somebody is living in a household with somebody who's pregnant or immunosuppressed, mothers that are breastfeeding, or infants that are breastfeeding, premature birth is not a true contraindication. Non-vaccine related allergies and non-anaphylaxis are big ones. So when it comes to eggs, the big question is if you have an egg allergy, what does it mean? So anaphylactic reactions to eggs is not a true contraindication to MMR. People with egg allergies, even severe allergies, can get the inactivated flu. Those with severe egg allergies really should be monitored, is the big thing, in the presence of an allergist with epinephrine available should they have anaphylaxis, with observation for 30 minutes. And a history of severe egg allergy in a family member is not a contraindication to influenza as well. So when it comes to diseases and medications, just remember that HIV-infected children should be immunized with inactivated vaccines, and they should they be exposed to measles, tetanus, or varicella, they should get associated immunoglobulin regardless of their immunization status. So you want to treat those individuals. And if you have a child who has HIV, a child who is HIV negative, but are living in a house with a patient with symptomatic HIV, they should get the MMR and varicella. And all household members greater than 6 months should get yearly flu vaccinations. So you really want to prevent the active disease in those patients. So you want to immunize them. Topical or inhaled steroids are not contraindications to vaccinations. Those receiving less than 2 milligrams per kilogram per day or less than 20 milligrams per day can receive live vaccinations. Those greater than that amount really should delay it for less than 14 days immediately after they stop their steroids to make sure they can have a good immune response. And if they have it for greater than 14 days, they shouldn't have live vaccinations until they've stopped them for at least 1 month. And then lastly, when it comes to vaccines, IVIG, recent administration of IVIG or blood products can interfere with the response to the live vaccine and a dampened response. So really the suggested intervals for blood transfusions are after 5 to 6 months, and after IVIG are 11 months for live vaccination administration. This is a chart that you guys will, again, want to go back and review and take some time to get to. You can certainly look this up, but the periodicity screening chart is how often different screening tests should be performed in children during their well-child visits. I would recommend you guys use your search engines to look this up and look at this chart and try to commit it to memory for the most part, so that you can have a better idea of who should be screened when and what should be done in terms of of not just history and their vital signs, but also vision screening, developmental screening, psychosocial screening, drug, alcohol, and tobacco screening, depression screening, all those different things, things like dyslipidemia. What kind of oral health screening should be done? This is the chart that is put out by the CDC that you guys should be using for a periodicity standpoint to review. So just to go through it just real quick, routine well visit screening, height, weight, and BMI at each visit for the head circumference for the first 3 years, blood pressure starting at 3, vision screen starting at 3, and audiometry starting at 3. Obviously, it has to be a cooperative patient to be able to do that, but you should at least attempt it starting at 3. Routine lab screening, so lead between 9 and 12 months, and then again at 2 years. More targeted testing for those known to be at risk. Iron deficiency screening should be done via hemoglobin between 9 and 12 months, and then again at 1 to 5 years for those at risk based on nutritional history or family history of disease processes. And then lipid screening is really recommended between 9 and 11 months, but sooner if there are risk factors for significant cardiovascular disease. When it comes to anticipatory guidance, there are a lot of areas to really follow up on. Firearms is a big one to look into, drowning prevention and how to prevent that, motor vehicle accidents, and particularly car seats and car seat safety. The weight limitations, the when to turn them around based on age and weight and all those sort of things are things you want to look at. For fires, and fire safety is another big one. There is a document that is included here that you can see, and I'll try to include the link in the email as well, which is a module to help you review and test your understanding of the different anticipatory guidance for kids based on the AAP recommendations. It is a very cumbersome thing to look through, but you can move through it pretty fast. It's 216 slides, but embedded in that allows you to test your understanding of what the true prevention areas are for safety. Screen time recommendations, again, the AAP recommends no screen time for those younger than 18 months of age, minimal screen time up to 2 years. The parents should be actively involved in participation. And then for those aged 2 to 5 years, no more than 1 hour per day. Behavioral guidance, so eating, sleeping, toileting, aggression, acting out, temperament, transitions of life, those kind of things are things, again, you'll want to review how to advise parents on how to improve eating habits, sleeping habits, toilet training, patients that are aggressive. Again, a lot of this stuff will be included in the PowerPoint that we send out that the chalk attendings do for you guys early on, but just make sure you kind of at least give that stuff a cursory look. All right, the last area here that we're going to cover is adolescent care. And so this counts for about 5% of the entire content in 4 big areas: growth and development, sex and sexuality, gynecology, and mental and behavioral risk factors. We'll try to spend a little bit of time talking about it. But don't forget in adolescence that weight doubles, during the adolescent period, and height grows 15 to 20% of the adult height. Peak velocity is earlier, obviously, in females than in boys. Growth lasts longer in boys, usually 2 to 4 years versus 1 to 3 years in girls. And for boys, muscle mass usually doubles during that 7-year time stretch. The psychosocial growth that happens is obviously a little bit different in adolescence. They're broken up into 3 categories. So there's early adolescence, middle adolescent, and late adolescence. This just kind of talks about some of the issues that you see, some of the things that happen during those time periods. So puberty starting in early adolescence, there's obviously body image issues, self-esteem issues. The idea of self-concept happens, and really they just want to fit in. Most of the time their peer groups remain their same-sex peer groups during that time period. In middle adolescence, they're becoming more comfortable with their bodies and selves. They're exploring outside of peer relationships with the opposite or same sex. Their emotional mood, though, starts to swing, and they start to have this increased sense of omnipotence, thinking it won't happen to them. And their relationships tend to be more me driven than anything else. And the parents tend to see a lot more kind of disagreements during this time period. And then late adolescence, the social relationships usually shift more towards groups again and not towards individuals. They become more intimate with their relationships, with about 41% of 10th graders having had intercourse and about 61% of 12th graders having had intercourse. So again, very, very intense relationships that are happening. Don't forget to review the sexual maturity ratings, so the Tanner scales for breast development and pubic hair development in females, and testicular development and pubic hair development in males. So this just kind of shows you the Prater scale and volumes associated with males, as well as the breast development in females that can happen. So average age of menarche in the US is about 12. Thelarche usually occurs between ages 8 and 11. Pubarche in boys usually is about 10 to 12. Peak incidence of gynecomastia, which we'll talk more about here in just a minute, is between ages 14 and 15, and usually resolves within 6 months to 2 years in boys. And then axillary hair, voice changes, and chest hair with males usually is about 2 years after pubarche occurs. Premature pubarche, thelarche, and puberty is obviously something that deserves a little bit more workup, and we'll talk a little bit more about that. So when it comes to sex and sexuality, just some things to think about and to know is that sexual orientation and gender identity usually begins to form around 2 years of age, and is usually solidified by 5 to 6 years of age. There's some data that shows that 5 to 10% of adolescents identify as homosexual, but more recent data suggests that number is increasing, and that a good number of adolescents have had same-sex experiences or relationships, and that really when it comes to the pediatrician's role in sexual identity and orientation, the role of the pediatrician is to have open and welcome communication, to help them with questioning that they may have during adolescent visits, and to create a therapeutic bond, so that you're providing accurate information to allow adolescents to develop their sexual orientation and gender identity as they mature in a non-judgmental way. And it really is a way to give them accurate information and safe information so that they're not coming into dangerous situations. When it comes to gynecologic stuff, we'll spend some time here. So indications for a pelvic exam, which should always be done in a chaperone setting, include abnormal vaginal discharge, menstrual irregularities, suspicion of imperforate hymen in a female with secondary sexual characteristics without with amenorrhea, and significant pelvic pain. Menstrual disorders, including amenorrhea, dysmenorrhea, dysfunctional uterine bleeding, and ovarian cysts are some things that we're going to talk about here in just a second. So for amenorrhea, this gives you guys a little bit of a pathway for secondary amenorrhea, and primary amenorrhea is really defined as no periods prior to 14 years of age or no periods by 15 with secondary sexual characteristics. The most common causes are anatomic or chromosomal in nature, particularly with Turner syndrome, or just physiologic delay, which is by far and away the most common that happens. Don't forget about the female athlete triad of amenorrhea, poor weight gain, and poor bone mineral density. Physical exam for primary amenorrhea really should focus on sexual maturity rating, vaginal patency, and signs of any sort of chromosomal abnormality. When it comes to the diagnostic workup of primary amenorrhea, pelvic ultrasound is usually one of the first steps. Blood work, including thyroid screening, CBC, and SED rates, are important to bone age to determine if there is just physiologic delay. FSH and LH are certainly helpful. A pregnancy test is always warranted early on to make sure that's not the cause of primary amenorrhea. And then for those that are found to have primary amenorrhea, a medroxyprogesterone challenge for withdrawal bleeding under the guidance of OBGYN is kind of the downstream later testing that might happen. Secondary amenorrhea is amenorrhea that occurs after 3 cycles, with with absence of 3 cycles after regular bleeding occurs. The most common cause of this is PCOS and pregnancy. The first step in checking for secondary amenorrhea would be to do a urine pregnancy test first, followed by the algorithm demonstrated on the right there, which includes some of that progesterone challenge for withdrawal bleeding. Don't forget to evaluate for secondary signs of hirsutism or virilization, and that will help you determine if there's androgen excess that may be causing a secondary amenorrhea. Dysmenorrhea is one of the most common complaints of adolescent females. About 80% of females will have some degree of dysmenorrhea, and most of those are related to primary causes. Usually begins with the onset of menstrual flow within and lasts 1 to 2 days. It's usually lower abdominal cramps with some potential nausea and vomiting and a normal exam. The treatment of choice is just heat, NSAIDs, and if moderate to severe or recurrent primary dysmenorrhea occurs, discussion of the use of oral contraceptive pills to help them out. Secondary dysmenorrhea is usually due to underlying pelvic pathology, most commonly due to sexually transmitted infections or endometriosis. The signs of STIs obviously include excessive bleeding, spotting or discharge, or a positive chandelier shine during examination. Endometriosis usually starts about 2 years after menarche, with 2/3 being tendered during the luteal phase. And for the patients with endometriosis, there is typically a strong family history of endometriosis. These patients should be evaluated by by OBGYN for potential scopes. They also may need oral contraceptive pills and surgery for potentially severe disease. Dysfunctional uterine bleeding is a big topic that is covered in the board examination. So menorrhagia and metorrhagia, so normal flow, normal interval with abnormal flow or irregular intervals with abnormal flow. Usually is due to unopposed estrogen stimulation, is typically painless. Both menorrhagia or metorrhagia are typically painless. If you add pain to it, then you're going to be talking about Mittelschmerz, which is described at the bottom there. Usually begins several years after menarche, with cycles occurring every 2 weeks or 2 to 3 weeks at a time. Your diagnosis is going to be based on your exam, making sure to check for STI testing, CBC to look for anemia. A strong family history of bleeding disorders might lead you to menorrhagia or metorrhagia as the cause for it. Then you may consider doing coags for severe anemia. The treatment of choice typically is oral contraceptive pills to help regulate the abnormal flow. Iron supplementation is needed. And for those with severe anemia, you're going to want to transfuse them. Ovarian cysts account for 20 to 50% of ovarian tumors in adolescents, so they can transform into cancerous lesions. And presenting symptoms usually for ovarian cysts include menstrual irregularity, severe constipation, urinary frequency by pushing on the bladder. They very rarely cause abdominal pain unless they are torsed, ruptured, or hemorrhaging. Follicular cysts are by far and away the most common type of ovarian cysts. They are usually unilateral and most of the time resolve spontaneously. If they are large, which would be diagnosed by ultrasound, so those greater than 5 centimeters. If they occur in patients that are premenarchal or have solid components to it, those should really be evaluated by GYN a little bit sooner. If there is a cyst which results in torsion, that also might be something that should be evaluated by GYN. And then if a cyst fails to resolve after 2 months of ongoing monitoring, those really should be evaluated by GYN as well. So the diagnostic test of choice, obviously, for a cyst is going to be a abdominal ultrasound to look at the ovaries. Luteal cysts tend to be a little bit larger. They tend to be more associated with heavy vaginal bleeding. Most of the time, they're not going to ask you to distinguish between follicular cysts and luteal cysts, but just know that follicular cysts are more common. Luteal cysts tend to be more associated with vaginal bleeding and tend to be larger. So breast disorders from a gynecologic standpoint, so we will touch on some breast disorders here. It's typically asymmetrical breast growth, but those things are fairly common in both females as well as males. Most breast masks are benign, luckily, in kids. Ultrasound is by far and away the initial diagnostic choice. If there are concerns based on the ultrasound, fine needle aspiration is the secondary test of choice. Fibroadenomas are 2/3 of all breast masks in females typically. They can occur in males, but typically in females, they're usually rubbery and well demarcated. They're non-tender and usually in the upper outer quadrant of the breast. Breast cysts tend to have more tenderness, usually around menstruation, usually regress after 2 to 3 cycles. Fibrocytic breast disease does result in cyclical tenderness with bilateral nodularity, so it's not the unilateral disease of cysts. OCPs can help with fibrocystic breast disease as well as decreased caffeine intake. Breast abscesses are things that you have to watch out for if they're fever, tender warmth, just like any other abscess, usually caused by Staph aureus. Trauma and eczema of the nipple typically occurs. That's usually the most common place for breast abscesses to develop. And then gynecomastia, we'll talk a little bit about here. So typically it's unilateral, only 20% are bilateral. Usually a tender, firm mass can be found under the areola. And late onset is more likely indicative of true pathology, but can be due to drug and medicines. Galactorrhea is often benign, but can be associated with different medicines and herbal supplementation. So please ask about or look to see if there are medicines or herbal supplements that are being used that might lead you to the diagnosis of galactorrhea. Prolactinoma followed by hypothyroidism are the most common pathological causes, can affect both sex, and may present as amenorrhea with failure of sexual maturation. So you want to get a TSH and prolactin as your first test of choice. Normal prolactin levels should prompt consideration of ovarian, renal, or adrenal tumors causing secondary elevation and problems with galactorrhea. Males with increased prolactin levels need annual MRIs to make sure they have not developed prolactinomas. And for tumors, surgery is typically the thing to do, plus or minus bromocriptine. With regards to contraception, abstinence is not the choice of contraception by the AAP. It is also not what the American Board of Pediatrics recommends. For emergency contraception, the indications include unprotected intercourse within 120 hours. So you want to remember that 120 hours, condom breakage, or more than 2 missed OCPs, or more than 14 weeks since someone's depot. So condom education should occur for all sexually active adolescents, and spermicides are not recommended. So further kind of talking about contraception, contraindications to some oral contraceptive pills include if someone is pregnant or lactating with intention to breastfeed, a history of thromboembolism, which you can see there, cerebrovascular accident or stroke, or migraine with neurologic symptoms. Those are all contraindications to oral contraceptive pills. The different types you can see here include the combined type, which is the most common type that will be used. Progesterone only type. Those are usually going to be used for those with contraindication to estrogen. The injectable types and implantable types that you can see there, and some of the things that come around with injectable versus implantable contraception. So some of the mental and behavioral issues associated with kids. So we're just going to talk about depression and conversion and those kind of things. But the most common things you'll see are somatoform disorders, depression, anxiety, and eating disorders. So conversion reactions are processes that are inappropriate response to anxiety and stress that you guys know. It does result in activation of the autonomic nervous system. So you will see some nervous system response to it, tachycardia, hyperventilation, vasoconstriction, and most often will model somebody else's symptoms that they've heard about or seen about. It's differentiated by hypochondriasis because they have relief or anxiety created through the investigation. So the people with conversion reactions are really going to have relief that you're looking into this versus hypochondriasis. They're having increased anxiety because they believe something is wrong, and they don't want there to be something wrong. Treatment is going to be good continual daily activity. Meds are rarely helpful or useful. Biopsychosocial approach with biofeedback is certainly something you want to do, and talking about minimizing of the symptomatology. For depression, it is often hard to discern that teens are already removed and moody by parents, but do remember your SIGI caps as things that can result in depression or show you that somebody is having depression. Biopsychosocial model is the way that these people should be treated, these young people, using counseling services along with medication managements. SSRIs, SNRIs, TCAs are the mainstay of treatment for depression. When it comes to substance abuse, 50% of teens are using alcohol during high school, 90% during use of tobacco and marijuana are also increasing. Increased incidence of comorbid psychiatric disorders with substance abuse. Most adolescents use them intermittently and experimentally, so it's not problematic behavior. The best predictor of progression to abuse are the age of first use, so the younger you are the first time you use it, if you are a male, and if your peers use substances on a regular basis. Those are the highest predictors of substance abuse and misuse in teenagers. In-office screening really should be performed to evaluate for progression from initiation to continuation maintenance phase. So it's not abnormal for them to experiment, but once they're more readily using it, that's what you want to try to prevent. And so that allows you to intervene sooner for counseling and intervention if needed. Pharmacological screening is not recommended. So if a parent comes asking for a teenager to be screened for drugs or alcohol, that is something that is not recommended by the AAP or by the American Board of Pediatrics. So that's not something that you would do even if they're asking you to do that. Counseling and certainly screening is more appropriate to improve what's going on for them. Smoking cessation is something that can be used in teenagers and is effective, including the use of nicotine gum and patches, but you want to do it along with counseling, always with counseling. So just real quick, we're going to move through. I know we're going on long here, but move real quick through eating disorders. So ARFID is one of the newest eating disorders. So avoidant restrictive food intake disorder, and the diagnosis is listed here. So you're going to have significant weight loss, significant nutritional deficiency, dependence on enteral feeding or nutritional supplements, and marked interference with psychosocial functioning. It can't occur with anorexia or bulimia, and really what they're trying to do is the patient is really avoiding food in every way possible due to concern about the consequences of eating. That contrasts with anorexia, which is the restriction of food leading to significant low body weight in the context of their age. It's an intense fear of gaining weight. So this is a problem with gaining weight and not the intake. It's the weight is the persistent behavior and fear there. And disturbance in the lack of recognition is another part of it. So there are two big types. There's a restricting type, usually excessive dieting, fasting, or exercise, versus the binge purge type, which during the last 3 months, the individual is engaged in recurrent episodes of binging and purging. Bulimia are recurrent episodes of binge eating characterized by eating in a particular amount of time too much under normal circumstances, lack of control over eating, recurrent compensatory behaviors to prevent gain weight. So they eat a lot and then they do something to prevent the weight gain. Inappropriately occurs for at least 1 week a month for three months, and is usually a self-evaluation is unduly influenced by body shape and weight. So they're worried about their body shape and weight, even if they are normal, versus anorexia, again, think they're too fat or too big despite a low body weight image. And it can occur with anorexia. So binge eating disorder is the final type of disorder that you'll see when it comes to eating disorders. This is eating an amount of food that is larger than what most individuals would eat in a similar time period, and a sense of lack of control over eating during these episodes. So they just can't can't stop eating. So it just really lacks the purge portion of things to create bulimia. So these episodes that they have occur with eating much more rapidly than normal, eating until they feel uncomfortably full, large amounts of food when not physically hungry, eating alone because of embarrassment, feeling disgusted with oneself, depressed, or even guilty afterwards. And again, the time period is the same for bulimia. It happens at least 1 week a month for 3 weeks, or for 3 months, excuse me. All right, and so that is everything that I wanted to cover. That's a ton of information. That probably could have been 5 very separate lectures about each one of those disorders, but at least hopefully that gives you some big bullet point areas that you can go back and review as relates to the different general pediatric topics, the ear, nose, and throat stuff, the allergy immunology, the dermatology, the well child and preventative care, and some of the adolescent stuff. Hopefully that's helpful. Let us know what we can do for you guys, and there'll be some more stuff coming your way related to other PowerPoint presentations. But enjoy the rest of the board review month, guys. Thanks.